Hello, everyone. My name is Maria. I am the chair of the FSEP Medical Student Council. I'm joined today here by Dr. Matt Slane from HCA Northwest Westside Emergency Medicine. So, Dr. Slane, if you'd like to introduce yourself and your program.
Matt Slane. I am the program director at HCA Florida Westside-Northwest. We are a accredited through ACGME, a 3-year program, 13 residents per year for a total of 39. We had our initial accreditation in 2021, and then we have our ongoing continuing accreditation status that we received from ACGME 2 years ago. That was just again renewed about a month ago. I think we got our continuing accreditation status just renewed again. So that's us.
Nice. Congratulations on that. So, I guess one question that we like to ask something just to get to know you guys a little bit better. If you could only eat one food for the rest of your life again, what would it be?
If I had to choose one food for the rest of my life, um, I would have to lean on my mom's side of the family, which is Italian. So I think my one food, if I had to pick one, would be lasagna that I could probably eat every day for the rest of my life.
That sounds delicious. I used to live in Jersey and obviously so many Italians up there and like best Italian food ever. So I can totally get down with that. So I guess moving on to your program a little bit, what are some of the key highlights of clinical training at your program, especially in the early years of residency?
I think definitely some of the highlights that we've got is based off of where we're located in South Florida. So typically, kind of going through the interview process, I talk with all the candidates about this. That South Florida is kind of a unique environment and really a perfect place to train in emergency medicine for a couple of reasons. One, that we have a very large and diverse patient population in South Florida. That there is, unfortunately, more people in need than hospital beds available for them. So there's a large volume of folks that need our help. And then on top of that, just because of the population that makes up South Florida, the um, the pathology that exists down here is probably more significant than any place that I've worked in my 20 years of doing this now, kind of across the country. It is basically the sickest patient population from a patient to patient basis that I have taken care of in the emergency department. It is definitely challenging to work in that environment, but it's amazing to train in that environment because you have the opportunity really to take care of the sickest of the sick patients every single day. Um, and then there's a large volume of those patients as well. So that's really, one of the biggest opportunities with our program that we get to expose our residents to, and then in an environment where we talk about that there's a lot of patients and the sickest patients at our West Side campus, we actually have the sickest patient population within our HCA divisions kind of down here in South Florida. They have a system that they rank how critically ill kind of the patient population is, and West Side out of our 14 hospital division is number one. So what that really provides for our residents from day one is the opportunity to take care of the most critically ill, unstable, decompensating patients. And they learn all the skills that are required to rapidly assess these patients, stabilize them, and provide that really that ICU level of care in the emergency department. And then what kind of goes along with these critically ill patients are all the opportunities for the procedural interventions that we have to be exposed to in emergency medicine training. So they really get the opportunity to build on those procedural skill sets as well, really day one.
Nice. Okay, sounds very well rounded, and it's nice to get that diversity in like sickness within patients, so they're really prepared for after residency. So I guess going off of that, how does resident responsibility itself progress through your program from like, intern year on to being a senior?
Yeah, so it depends, I would say, definitely on the individual resident because we all come in with different levels of experience. We've had different opportunities, whether it was before we went to medical school, in medical school, where we had rotations, opportunities we got, and things like that. So our goal is definitely early on in their first year with us is we want to be able to provide a strong foundational knowledge and a strong procedural knowledge. So there is a lot of bedside teaching, a lot of kind of walking through patient care, just to ensure that we're not making assumptions on folks' ability, but it is a kind of joint management process. So it's not me as the attending just talking, telling the resident what needs to be done. We discuss the patients and kind of come up with a plan together. As the experience level builds, it's less of the discussion on the approach to maybe what the chief complaint is, and a little bit more kind of diving into, you know, some of the broadened differentials and um, what could be some concerning physical exam findings or concerning parts of the history, and just trying to kind of go a little bit more deeper into sometimes the physiology of what may be some of the more concerning um, processes that the patient may be showing up with. With that being said, as we develop things like procedural skill sets, it doesn't require necessarily as much direct observation doing certain procedures. They can do it, on indirect. Once you've demonstrated that you can appropriately, repair lacerations, your attendings don't have to be at the bedside while you're doing it, or incision and drainage of abscesses, things like that. There will be certain procedures that, your attendings will always be there for, whether you're a first year, second year, or third year. If a patient's being intubated or we have, a cardiac arrest and CPR and the whole resuscitation process is going on, we will always be in the room with you. So you're never going to be, completely just stent out on your own as well, because that's another balance. The whole purpose of residency and 3 years of residency is to have that opportunity to work kind of continuous with your attendings, and look for opportunities to learn. So, nobody's going to completely, cut you off either to that extent, but we don't want to necessarily change, small little adjustments to your management or small adjustments to your plan if it's still within the scope of kind of what we're looking to do for the patient, because we have to allow each of the residents to kind of develop their own practice pattern, and their own approach to different chief complaints, how they're going to work up um, different complaints in the emergency department. So it's a gradual increase in responsibility, a gradual kind of stepping back from the attending, where we may be a little bit more involved early in the career, and then maybe some little adjustments as they kind of get into their second year and third year, to allow them to take on a little bit more and more responsibility.
Okay, great. And so I know that you were saying, you guys do like some of that bedside teaching with, with patients and stuff. So then how does the curriculum balance that clinical experience that you were just talking about with didactic experience?
Yeah, so we have a fixed didactic schedule. We have an 18-month curriculum that repeats. So you'll go through the curriculum twice in a 3-year period. Our didactics are Wednesdays. So 8 a.m. to 1 p.m. is protected time for the residents. So that's an opportunity for them to always be a didactic. So, whether they're on an off service rotation in the emergency department, the, the, their kind of place of business during that time is at didactic. So that's protected time, for the residents to be part of it. And then, from a clinical standpoint, obviously you can't go into necessarily lecturing and in depth with some things. You're just always looking for opportunities to reinforce or potentially, find some potential areas where we can improve in our knowledge base, and then, have some of those discussions and talk about it, and then apply it back to what we learn in kind of more of the academic setting and didactics.
Yeah, for sure. I feel like even as, being a third year going into rotations, like that bedside teaching as we're walking down the halls and stuff is honestly what really sticks with me because you're learning it from the attending himself. So then I guess going off of how you were saying with off service and stuff, how much elective time is built into your program and or how flexible is it for residents to explore subspecialties within EM?
So we do a 28-day block schedule, which gives us 13 blocks in a 12-month period. So we have an elective rotation in our PGY2 and our PGY3 year. So they get the opportunity in their second year and in their third year to do an elective rotation. We have a lot of electives that the residents have already done, and those are opportunities to be able to um, kind of step in and do a rotation in something that we kind of is a known experience. That being said, we also allow the residents to explore elective opportunities that we haven't done yet, as long as it's, like you said, within kind of the emergency medicine field. HCA is very supportive that one of the two electives can actually be outside of the HCA system itself. So that is a little bit more work on our part because anytime, unlike as a medical student where you can easily kind of go to another institution and be a visiting medical student for a rotation, it's a little bit more challenging in residency, as you can imagine, because you're an employee, have a job, malpractice insurance, kind of all those type of things. So in order for us to send one of our residents to another institution, there has to be an agreement between our institution and the other institution, basically a contract, a program letter of agreement, which is, our lawyers talking to their lawyers, just making sure everybody's appropriately covered. So there's a little bit of a process in creating that, about a 90 to 120 days. Um, but we are more than willing to kind of create those opportunities for our residents to be able to explore elective opportunities outside of our system. And we've been very successful sending people really to hospitals around the country. And when you're talking about potentially applying to fellowships, just like um, some of my residents are doing now, it's just that in-person opportunity to rotate for a month sets them up for success to be able to potentially come back as one of their fellows in the future.
Yeah, for sure. And so going on to the residents, what does a successful resident at your program look like?
So it's a common question that I think I get during interview season the whole time, and I don't know if my answer is similar or not to probably other folks you talk to, but at least my approach to it is, what I say the successful residents will be has nothing to do with your procedural skill set coming in or how much emergency medicine kind of day one when you come into the department. It's my job as the program director and the job of my associate program directors to teach the residents emergency medicine. So to be successful in the program is more what I say is kind of attitude based, in the sense that emergency medicine is a hard and challenging residency. You will be very busy every single time you step into the hospital. You will have to work in a team environment every single time you step into the hospital. Emergency medicine, is kind of a team sport. It's not one of these ones that, you kind of practice in isolation. So it's more of the personality of the folks coming in. If you are willing to work hard and understanding that it's going to be hard work, you're willing to work with other folks as well in for the betterment of your patients. That's what I think it is needed to be successful. And then kind of the last piece of it is there has to be a self-motivating component as well. And the reason that I say that is because our subspecialty is so broad. We touch every system in the body, we touch every subspecialty. We have to have a knowledge base of kind of what they do from a medical standpoint. So, regardless of how many shifts you work in the emergency department, regardless of, all the hours that we do in didactics, we're never going to be able to cover the full breadth that is emergency medicine. So, there has to be a self motivated component of being your own kind of self-motivated learner as well. There has to be some opportunity to read on your own, or when you have an interesting case and there was something that you didn't exactly sure how things went, going back and looking it up and kind of filling in some of those gaps. So, kind of self-motivated, um, kind of team player, kind of ready to work. I think if you have those three components, like with our patient population that I mentioned down here and our volume that's down, like we will teach you emergency medicine in 3 years.
Yeah, for sure. It's, medicine is what the never-ending learning experience. So definitely being self-motivated to study after those long shifts is for sure important. So I guess going on to you were saying the teamwork and team aspect that is emergency medicine. What do you guys do to promote wellness amongst your residents?
So we have a few things that I think, you know, most programs have got a wellness program kind of in place now. We have one of our core faculty members. She's the chair of kind of our wellness committee and is constantly looking for opportunities to connect with the residents and provide kind of um, opportunities for them to decompress, or areas to be together outside of emergency medicine, or opportunities to do things that are fun, just kind of social gatherings. So that's kind of one component of it. The other, I think, aspect of wellness is how supported we feel kind of within our program as well. So a big aspect of kind of the culture that myself and the APDs have looked to kind of foster within our residency is really, we want to build this family mentality to our program. And the reason I use family is a little bit different. And one, we are a support network for each other. With a lot of people that are away from their families, we kind of become the family away from family. That's one aspect of it. But the second part of it is, in my life, I could always trust in my family to kind of be the most transparent and honest with me, with the best of intent, kind of what they're telling me. And that's really the approach we also want to have for the residents. If we see an opportunity where things can be better, it's not a nitpicking issue. It's because we see greatness and we think we can get there. We're not going to ignore something. We will come and directly approach it to you and talk to you, and um, come to a resolution. And I think, what that creates is that support network that people feel in a family kind of creates a self of wellness as well, because you have a true sense of belonging, because you're not just an employee who shows up. You're part of this family that is in this together. All, I would say how many people, but the residents plus the faculty plus everybody, it's a joint mission and vision together. So there's going to be tough times, there's going to be bad shifts, there's going to be poor outcomes. That's unfortunately the subspecialty we're in. But feeling supported kind of through that also helps with the wellness. When you are struggling, you have the people that you can turn to. When you are you know feeling burned out, or that you had, or you just need somebody to listen to you, you feel comfortable having those people. So I think that's a big component of the wellness as well.
Yeah, for sure. I liked how you said the family aspect and the people that are most honest to you, because it's true. I think that in residency, the best way to improve is with that feedback that you're saying, as well as having the support to be able to turn to the people in your class. So I guess one final question before the takeaway is, how can applicants stand out, and what do you look for with students on rotations or just when they're applying to your program?
Yeah. I think that's a difficult question. In what the interview season looks like right now, especially since we've gone to a virtual format. I know it can be challenging, because 6 years ago everybody interviewed in person and it was a little bit different. Obviously, if you can rotate at a facility, I think that puts you in the best situation to be successful, because you get more than a 15-minute snapshot at somebody. Um, you know, but we understand that everybody can't rotate everywhere. And then I would say the next kind of step is if, a facility has a in-person second look or a virtual hangout opportunity or somewhere where you can just have more FaceTime with the program. I think that also helps, but it's not a necessity. I can tell you personally, there's not a magic thing that I look for in somebody's um, packet. It's not a special board score or a rotation. We do, if it is possible to get an electronic slow written, just because I think personality wise, a lot of us in emergency medicine are pretty similar, and it just gives us at least some insight of how a month of your time went as opposed to just an interview. So I think that would be the best thing that I could say. If there's an opportunity to make an in-person impression, I think that's always the best. But you know, I don't think it's a necessity by any means.
Awesome. Okay. Sounds good. So then I guess what's one final message that you want applicants to take away from your program?
So, when we started this program, um, I guess it's almost 5 years ago now. My goal was to prepare our residents to be able to be successful in any work environment when they graduated. I never wanted them to be looking at a job and just say, oh, this would be a perfect job, but I just don't think I have the skill set to kind of step in and do this job, whether the hospital's too busy, whether the hospital's a rural facility, whether they have a lot of subspecialty coverage or limited subspecialty coverage. So really that has been the driving goal of our program. So we are in a very urban area in a very busy hospital system, um, but with every subspecialist pretty much that kind of exists. But we have maintained autonomy within our emergency department, which means our residents get to manage, every intervention, every kind of patient that comes into the emergency department. So if they do go and work at a large tertiary center when they graduate, they're very comfortable working in that environment because they've been working in that environment. Or if they go to the other end of the spectrum and work at a critical access hospital where they may be the only physician in the hospital after hours and they have to provide prolonged kind of critical care management to patients as they're waiting to transfer them out to a bigger facility, they feel very comfortable with that because they still had the opportunity to do that as well, kind of within this environment. So we've been very intentional in creating those opportunities to really set them up that there is no work environment that they should not flourish in when they graduate.
Thanks so much. Yeah, no, it sounds like you have a great program. Thanks for all the information that you gave today. I'm sure that students will find this extremely helpful as they move on through applications and applying for away rotation. So thank you so much again.
Thank you.